Welcome to the Deep Dive. We're here to help you really sharpen your understanding of a critical topic for your revision.
That's right.
And today, we're diving deep into diabetic retinopathy, DR.
Yeah,
Think of this as your sort of high-yield guide.
exactly. We've taken the key info, like from MSRA revision notes, and we're aiming to give you a really clear, concise overview, just what you need for effective learning.
Perfect.
Our mission today is basically to pull out that core knowledge you need to feel confident about DR.
Fantastic. So we'll cover the whole range definition, causes, risks, what's actually happening in the eye, right through to management and complications.
And we'll sprinkle in some memory aids, too, hopefully make things stick.
Yeah, keep it practical. It's all about making the most of your revision time, getting a solid grasp without getting bogged down. So let's kick things off. What exactly is diabetic retinopathy?
Okay, so diabetic retinopathy, DR, it's fundamentally a complication of diabetes. It specifically affects the blood vessels in the retina.
The back of the eye.
Right, those tiny vessels, vital for vision. It's progressive, which is it can get worse over time. And importantly, it's a major cause of blindness in working age adults, say 35 to 65.
Wow, okay.
The basic problem is damage to these small retinal vessels because of diabetes, which leads to, well, leakage and blockages.
Right.
And we usually split it into two main types. Non-proliferative, NPDR, that's the earlier stage, and proliferative PDR, which is more advanced.
More serious.
Definitely more of a threat to vision. And it's worth mentioning the UK screening program, that annual retinal photo.
Yeah, super important. That really underlines why we need to know about it. So what's the root cause, the etiology?
Well, the primary driver is having diabetes mellitus, especially when it's not well controlled over a long period.
So chronic high blood sugar.
Exactly. Chronic hyperglycemia. It directly injures those small retinal blood vessels. That injury kicks off a cascade, leading to abnormalities in the vessels and eventually those occlusions, the blockages we mentioned.
Got it. So prolonged high glucose is the trigger.
Precisely. But it's often not just the glucose. Other conditions common in diabetes can make it worse, accelerate the damage.
Like what?
Things like hypertension, high blood pressure, and dyslipidemia, so abnormal blood fats. They can really ramp up the progression of DR.
Okay, sort of adding fuel to the fire.
That's a good way to put it, yeah.
So beyond that poorly controlled diabetes, what are the specific risk factors that make someone more likely to get DR or for it to get worse?
Right. Several key things. Poor glycemic control is number one. The higher your HbA1c and the longer you've had diabetes, the higher the risk and the faster it tends to progress.
Makes sense.
Hypertension and dyslipidemia, as we just said, are big ones too. Microalbuminuria, that's protein in the urine, an early sign of kidney issues, is another important flag.
Anything else on that list?
Yes, definitely. Pregnancy can be a trigger for worsening DR in women who already have diabetes.
Yeah.
Smoking is a
A
factor.
quantifiable one.
Yes. We also see it more often in some minority ethnic communities with type 2 diabetes here in the UK. And though it's maybe less direct, there's some thought that eye surgery, intraocular surgery, might potentially increase risk in certain people.
Interesting.
But always remember, the duration and severity of the high blood sugar are central. And kidney disease, proteinuria, high urea, or creatinine, that's a strong predictor too.
And you mentioned pregnancy risk.
Yeah, particularly high risk if there's already severe retinopathy at baseline, or if glucose control is poor, if diabetes is long-standing, or if there's also hypertension.
Okay, that paints a clear picture of vulnerability. Let's zoom in now on the pathophysiology.
Yeah.
What's actually happening mechanism-wise inside the eye?
Right, this is where you see the sequence. High blood sugar damages the vessel walls. This leads to microaneurysms, tiny little bulges.
Okay.
The damaged vessels also become leaky, so fluid, fats, proteins seep out, forming exudates. Then some vessels get blocked off entirely. Exactly, ischemia. Lack of oxygen to parts of the retina. This lack of oxygen triggers the release of growth factors. VEGF is the main culprit you hear about.
VEGF.
Right, and VEGF tells the retina, we need more blood vessels. So you get neovascularisation, new vessel growth. The trouble is, these new vessels are abnormal, fragile,
Prone to bleeding.
yes, and leaking. And alongside all this, you've got inflammation playing a role, oxidative stress. It's a complex cascade.
So it's like a chain reaction from that initial damage?
Pretty much. The hyperglycemia hits the endothelial cells, lining the vessels, causing dysfunction, making them permeable, hence the leaks and exudates. It also affects parasites, the cells supporting the vessels, contributing to those microaneurysms.
Okay.
Then you have the blockages, microvascular occlusion leading to ischemia. Ischemia leads to VEGF release, causing abnormal connections, shunts, and that dangerous neovascularization. And the leakage causes the hemorrhages and the swelling, the edema.
That's a lot going on. Is there a way to summarize those key steps?
We could try a mnemonic. How about damn and hype?
Damn hype.
Yeah.
Okay, break that down.
Damage to vessels, aneurysms, microaneurysms, neovascularization, hemorrhage, ischemia, and permeability. Captures the core processes.
Damn HHE. I like it.
Yeah.
Okay. And how do we classify this damage? You mentioned stages earlier.
Yeah. Classification is key for severity and treatment. It starts simple. Background NPDR, that's just microaneurysms present.
Okay.
Then moderate NPDR, you've got microaneurysms plus some hemorrhages, maybe hard exudates, cotton wool spots.
Right.
Severe NPDR is more extensive. You see those features across multiple quadrants of the retina, plus maybe more marked vessel changes like venous beading or loops, IRMA.
IRMA being?
Intraretinal microvascular abnormalities, kind of
Right.
like shunts within the retina itself, a sign of significant ischemia.
Got it. And then PDR.
Proliferative DR, PDR, is defined by the presence of neovascularization, those new vessels. We can split that further into non-high-risk and high-risk PDR based on how many new vessels there are, where they are, and if there's associated bleeding or detachment risk.
And maculopathy.
Ah, yes. Diabetic maculopathy is when the damage specifically hits the macula, the central vision area. This can manifest as macular edema, swelling, ischemia, lack of blood flow, or what we call clinically significant macular edema, CSME, which has specific criteria based on proximity to the fovea and associated features.
Okay, that stratification makes sense. Now, thinking clinically, if someone presents with eye symptoms, what else should be on our differential diagnosis list besides DR?
Good question. Crucial for exams. You absolutely need to consider other things. Retinal vein occlusion is a big one, can also cause hemorrhages, vision loss.
Okay.
Hypertensive retinopathy. High blood pressure can cause similar signs. Flame hemorrhages, exudates, cotton wool spots.
Right, shared risk factors too.
Exactly. Age-related macular degeneration, AMD, especially the wet form, affects central vision, so there can be overlap in symptoms, though the signs are usually distinct.
Yeah.
And glaucoma primarily affects peripheral vision first and the optic nerve, but sometimes advanced DR can cause neovascular glaucoma, rubeosis iridis, which presents differently, so keep it in mind.
Any quick memory trick for those differentials?
Maybe just think. Other vascular issues, vein occlusion, things linked to similar risks, hypertension, other macular problems, AMD, and other major sight-threatening conditions, glaucoma.
Useful. Okay, let's shift to epidemiology. How common is this, particularly in the UK?
It's really common, a major cause of visual impairment. And the longer someone has diabetes, the higher the chance they'll develop some form of retinopathy.
Both type 1 and type 2.
Yes. It's actually more prevalent in type 1 over the long term, but because type 2 is so much more common overall, it's a huge issue there too. Diabetes is a leading cause, maybe the leading cause, of severe sight impairment in working age people.
That's stark.
Yeah, and macular edema specifically affects maybe around 9% of everyone with diabetes.
Can we break down the type 1 and 2 numbers a bit more?
Sure. For type 1, data suggests around 37% show some retinopathy at their very first screening after diagnosis. Risk goes up with duration, higher HbA1c, and higher diastolic BP. Interestingly, diagnosis at age 12 or older seems slightly higher risk too.
And type 2?
With type 2, remember, high blood sugar might have been around for a while before diagnosis. So it's not unusual to see retinal changes right at the point of diagnosis.
Ah, right.
Looking long-term, say over 25 years, the numbers are pretty high. About 83% develop some DR, maybe 29% get macular edema, and 17% get that clinically significant macular edema.
Wow, really highlights the need for that screening and early management. So how does DR actually present? What clinical features might a patient notice, or what would we see?
Well, the tricky thing is, in the early stages, often nothing. It's asymptomatic.
Hence the screening.
Exactly. As it progresses, people might start noticing things like blurred vision, maybe distorted vision, floaters appearing in their sight or their vision fluctuating. Some report issues with color or dark patches, maybe empty areas in their field of vision.
And clinically, we're looking for those signs corresponding to the classifications.
Precisely. And PDR, mild, moderate, severe, PDR, or maculopathy.
Remind us of the key signs for each again.
Okay, mild NPDR, just microaneurysms.
Hmm.
Moderate NPDR, add in some dot blot hemorrhages, hard exudates, maybe cotton wool spots. Severe NPDR. More widespread hemorrhages, microaneurysms across all four quadrants, plus venous beading, maybe IRMA.
Got it.
PDR is all about the neovascularization, new vessels on the retina or optic disc. Sometimes you see fibrous tissue forming too, more common in type 1,
Okay.
and maculopathy. Look for changes at the macula, hard exudates there, thickening suggesting edema, and check the visual acuity, as that's often affected. Maculopathy is probably more common in type 2.
And you mentioned the long-term incidence is high.
Very high. After 15 years, over 90% with type 1, maybe 60% with type 2 will have some retinopathy. Symptoms might be minimal initially, maybe just floaters or slight blurring.
But more advanced symptoms can occur.
Oh, yes. Gradual central vision loss from maculopathy. Sudden painless floaters if there's a vitreous hemorrhage. Sometimes acute severe vision loss from a major bleed. Or even acute painful glaucoma if rubeosus iridis develops.
So the examination is crucial.
Absolutely. Checking the red reflex, doing a dilated fundus exam, systematically looking quadrant by quadrant for all these signs, and specifically looking at the macula, often with a slit lamp, is vital for assessing potential macular edema.
Okay. So what specific investigations confirm the diagnosis and help monitor DR?
Well, the comprehensive eye exam itself is key visual acuity dilated fundus check. But the mainstay for screening and often monitoring is digital retinal photography.
The photos from the screening program.
Exactly. Then we have OCT, optical coherence tomography. That gives incredibly detailed cross-sectional scans of the retina. It's brilliant for detecting and quantifying macular edema, seeing subtle changes.
Very useful for maculopathy.
Definitely. And then there's fluorescein angiography. We inject a dye into the arm and it circulates to the eye, highlighting the blood vessels. It shows leakage, ischemia, neovascularisation really clearly. It's often used to guide laser treatment.
So photography is the base. OCT adds detail, angiography guides treatment.
Broadly, yes. Dilated photography is the gold standard for initial diagnosis, maybe supplemented by ophthalmoscopy. OCT and angiography help refine things and plan management.
And what about the NICE guidelines on screening and referral? What are the key points there?
NICE is pretty clear. If you're diagnosed with type 2 diabetes, you should be referred immediately to the screening service.
Immediately. Yeah.
Yes. Anyone with a sudden, unexplained drop in vision needs urgent referral to an ophthalmologist. For kids with type 1, annual screening starts from age 12.
And for adults?
Adults with type 1 or 2 need annual screening. Dilated pupils, retinal photos, visual acuity check, starting right from diagnosis.
Okay. When are emergency or rapid referrals needed?
Emergency review for sudden vision loss, rubeosus iridis, pre-retinal or vitreous hemorrhage, or if you suspect a retinal detachment. Rapid review if new vessels, PDR, are detected.
And standard referrals?
Referral if screening picks up referable maculopathy or pre-proliferative retinopathy, according to the national criteria. Generally, monitoring starts age 12 for both types, but you might consider referral earlier for under 12s if their glucose control is very poor.
So fundus photos are usually enough for screening, but OCT is becoming more important.
Increasingly so, yes.
Yep.
For earlier detection, better staging, tracking progression, especially regarding the macula.
Right, that makes sense. So once DR is diagnosed, how do we actually manage it? What are the pillars of treatment?
Management really revolves around a few key areas. First, and arguably most important, is tackling the systemic factors.
The ABCs.
Exactly. Optimal glycemic control, A1C, blood pressure management, BP, and lipid control, cholesterol. Getting those sorted is fundamental to slowing things down.
Crucial. And then the eye-specific treatments.
Then we move to direct ophthalmic interventions. The main ones are laser photocoagulation, intravitreal injections, usually anti-VEGF drugs, and in more severe cases, vitrectomy surgery.
And regular checks are key throughout.
Absolutely. Regular screening and timely intervention based on the findings are critical to prevent vision loss.
Can you break down the management for different stages?
Sure. For everyone with diabetes, optimize those ABCs, get regular eye reviews. If there's maculopathy causing vision changes, intravitreal anti-VEGF is usually first line.
Okay.
For NPDR, it's often watchful waiting, regular observation. But if it becomes severe NPDR, we might consider panretinal laser to reduce the risk of progressing to PDR.
And for PDR itself?
For PDR, the mainstays are panretinal laser, PRP, and or intravitreal anti-VEGF injections, often used together. Vitrectomy surgery comes in if there's a severe vitreous hemorrhage that won't clear, or if there's tractional retinal detachment.
Let's dig into those treatments a bit. Laser first, how does that work?
Laser photocoagulation involved creating tiny burns on the retina. In PDR, panretinal photocoagulation, PRP, treats the peripheral retina quite extensively. This reduces the oxygen demand, which in turn reduces the stimulus, like VEGF, for new vessel growth.
So it stops the neovascularization drive.
That's the aim. For macular edema, focal laser targets specific leaking microaneurysms to try and seal them off. Laser can halt progression, but it doesn't usually restore vision that's already lost.
Okay. And the anti-VEGF injections.
These target that vascular endothelial growth factor we mentioned. VEGF drives neovascularization and makes vessels leaky. By injecting anti-VEGF drugs directly into the eye, intravitreally, we block VEGF's action.
Reducing new vessels and leakage.
Exactly. Very effective for diabetic macular edema and also used alongside or instead of laser for PDR. Drugs like ranibizumab, aflibercept, bevacizumab fall into this category. Ranibizumab has specific, nice backing for certain DME situations.
What about steroids? You mentioned them briefly.
Yes, intravitreal steroids like triamcinolone or implants like fluocinolone can also be used for DME. They work by reducing inflammation and leakage.
But downsides?
Potential side effects are the main concern, mainly increased eye pressure, glaucoma risk, and cataract formation. So it's a balance. The fluocinolone implant is more for chronic DME that hasn't responded well to other treatments.
And vitrectomy surgery, when is that the route?
Primarily for complications of PDR. So a dense, vitreous hemorrhage blocking vision that doesn't clear on its own, or tractional retinal detachment where scar tissue is pulling the retina off.
What does the surgery involve?
Removing the vitreous gel, which is full of blood, or pulling on the retina, peeling away scar tissue, repairing the detachment if needed, and often applying laser PRP during the surgery itself to treat the underlying PDR.
Right, clearing the view and fixing the structure. That's a clear treatment pathway. Any way to easily remember the overall management approach?
How about ABC, then lives?
Okay.
A1C control, blood pressure, cholesterol management, then laser, intravitreal injections, VEGF steroids, vitrectomy surgery, eye checks, regular screening, and stop smoking.
ABC, then lives. Covers the bases.
Nice.
So looking long term, what's the prognosis generally like for someone with DAR?
It's really variable. It hugely depends on the stage it's caught at, how well the diabetes and blood pressure are managed, and the response to treatment.
So early detection is key.
Absolutely. Early detection, good systemic control, regular monitoring, timely treatment, all of these can significantly slow progression and minimize the risk of severe vision loss. But it has to be said, advanced stages, even with treatment, can unfortunately still lead to significant visual impairment or blindness.
A sobering reminder.
Yeah.
Finally, then, what are the main complications we need to be aware of, both from the disease and potentially the treatments?
The main ways DR causes vision loss are macular edema, blurring central vision, macular ischemia, permanent central loss due to lack of blood flow, vitreous hemorrhage, sudden floaters or vision loss, and tractional retinal detachment, severe vision loss.
And treatment complications.
Yes, treatments aren't without potential issues. Laser, both focal and panretinal, can sometimes affect central vision, cause blind spots, gotomas, or worsen night vision. PRP, the more extensive laser, is more likely to constrict the visual field or reduce night vision. Intravitreal steroids, as we said, carry risks of cataract and raised intraocular pressure. Anti-VEGF injections have small risks associated with the injection itself, like infection, but are generally well tolerated systemically.
Good to be aware of those trade-offs. Well, thank you. That was an incredibly thorough walkthrough of diabetic retinopathy. Really helpful for nailing down the key revision points.
My pleasure. It's definitely a core topic, and getting a good handle on it is essential.
So just to quickly recap our deep dive, we've covered the definition of DR, its causes, the risk factors, the underlying pathophysiology, remembering DAM, HYPE, how to differentiate it, the epidemiology, clinical features, investigations, the ABC, then lives management approach, prognosis, and potential complications.
Hopefully that gives you a solid framework. Remember those key risk factors, the disease stages, and the corresponding management. And always, always emphasize the importance of early detection and good systemic control.
Absolutely. And maybe one final thought for you, our listener, to ponder. With diabetes becoming more prevalent globally, how do you think ongoing advances in, say, AI for screening or new therapeutic targets might change how we detect and manage DR in the future, potentially reducing its impact on vision worldwide?
A really important question for the future.
Definitely something to think about. For more resources to boost your MSRA prep, do check out PassTheMSRA.com.
And don't forget freemsra.com for lots of valuable free content as well.
Thanks for joining us for this deep dive today.